Aurora Brown and Intersectional Psychology acknowledge the traditional owners and custodians of country throughout South Africa and their connections to land, water, and community. We pay our respects to their elders past and present, and extend that respect to all Indigenous people listening today. Intersectional Psychology. The PsySSA Guidelines. Everything the anti-trans crowd pretends isn't real. Hosted by registered counsellor Aurora Brown, with special guest clinical psychologist Thembisile Dlamini. This episode is for educational purposes only and is not intended to be a substitute for professional health advice, diagnosis, or treatment. Aurora Brown and Thembisile Dlamini are not able to answer specific health questions about individual situations. Always seek the advice of your health provider with any questions you may have regarding your health care and health conditions. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen on this podcast. If you think you need immediate assistance, please call your local emergency number or any mental health crisis hotline. Hello listeners, just a quick heads up that we re-recorded several sections of this episode, so you might notice some differences in audio and video. And also to acknowledge that I know the audio quality on this podcast is not 100% optimal. This is a one-woman show, and in this early period of my podcasting journey, I have tried to focus on bringing you meaningful and valuable content, but I am also working on improving my mixing and production skills, so it is a work in progress. So thank you to everybody who is bearing with me and who is enjoying the content despite the sound quality. Now let's get on with the show. Hello and welcome back to Intersectional Psychology, the podcast that explores psychology's role in promoting social justice. I'm your host, Aurora Brown. I'm a registered counsellor in Cape Town, South Africa. Today we are continuing our series on the health of trans and gender diverse people. Last week we spoke to Dr. Anastasia Thompson about what the medical guidelines for gender-affirming healthcare actually entail. But as a mental health practitioner, there is actually another set of guidelines that is even more relevant to the work that I do. This is the practice guidelines for psychology professionals working with sexually and gender diverse people, published by the Psychological Society of South Africa, or PsySSA, and the African LGBTQIA+ Human Rights Project. Considering their focus on mental health and psychosocial care, I think these guidelines could be useful not just for mental health practitioners, but also anyone who wants to engage respectfully and empathetically with sexually and gender diverse people. The second edition of these guidelines was launched earlier this year, and today we are very fortunate to have as our guest one of the co-authors of these guidelines. Thembisile Dlamini is a clinical psychologist who has recently completed her internship at Weskoppies Psychiatric Hospital and is about to embark on her community service year. She also recently completed her Master of Arts in Clinical Psychology cum laude at the University of South Africa, also known as UNISA. After a 14-year career in finance, she transitioned to psychology, driven by her passion for mental health and the desire to have a meaningful influence. Thembi holds a Bachelor of Arts in Social Science and a Bachelor of Arts Honours in Psychology, both from UNISA. A proud alumnus of the Young African Leadership Initiative, or YALI, she earned a certificate in public management in 2017. Thembisile is passionate about advocating for LGBTQIA+ individuals, women and children, particularly from disadvantaged backgrounds who face barriers to mental health care. She is committed to providing affirmative support to empower these vulnerable populations. Driven by a strong sense of social justice, Thembisile creates safe, equitable spaces for healing and resilience, helping clients overcome systemic challenges. She is a member of PsySSA SGD Executive Committee and the PsySSA SGD African LGBTQIA+ Human Rights Project. So Thembisile, welcome to the podcast.
Thank you very much, Aurora. Thank you for the invite and thank you for that wonderful background.
Introducing PsySSA's practice guidelines for psychology professionals working with sexually and gender diverse people, 2nd edition. So the Sexuality and Gender Division of the Psychological Society of South Africa, the PsySSA, released the practice guidelines for psychology professionals working with sexually and gender diverse people earlier this year. And I read in your bio that you are part of the executive committee of the SGD division. And you're also one of the co-authors of these guidelines. I'm going to include a link to the guidelines in the show notes. But when people talk about gender-affirming healthcare in the context of psychology, these guidelines are what they mean. This is the 2nd edition of the guidelines, which were updated from the 1st edition released in 2017. It is still the only set of such guidelines from the African continent, and it is an incredibly comprehensive and evidence-based document. You were one of the authors of these guidelines, so I really am so appreciative to you for taking the time to be here. One of the most common criticisms of the gender-affirming approach is that it lacks evidence. And yet this document is extremely well referenced. Literally, the reference list alone is 30 pages of internationally peer-reviewed journal articles and best practice documents. So I guess the point is that the people asking where is the evidence aren't really approaching the topic in good faith, and they don't really want to hear the answer, but we do. So I was wondering if you would like to talk a little bit about the evidence behind these guidelines before we dive into them.
So firstly, I would like to say these updated guidelines and the previous ones are grounded in a strong body of peer-reviewed research, which is from both an international perspective and an African perspective. And the evidence strongly supports gender-affirming care as effective in improving mental health outcomes, and particularly in reducing distress, suicidality, and internalized stigma. So the development process spanned over 2 years and involved a multidisciplinary team of psychologists, experts in the field, and critical literature reviews, national surveys, stakeholder consultations, and peer review by 23 experts. So this was a rigorous collaborative approach rooted in both clinical practice and lived realities. So the guidelines are informed by affirmative practice, intersectionality, decoloniality, and feminist theory, which offers a contextual, ethical, and human rights-based approach to care. So the evidence is there. There's a lot of work that was done in the background to come up with these guidelines, to develop these guidelines. And these guidelines are linked. If you look at our South African Constitution, they are linked to that. If you look at our ethical guidelines as mental health care professionals, they also speak to that. If you look at all the legal documents, we made sure that these guidelines speaks to those legal documents, and also obviously the research that went into developing the guidelines speaks for itself.
Thank you. So there is ample, credible, reliable, validated, peer-reviewed evidence supporting gender-affirming healthcare. On the other hand, the critics of gender-affirming healthcare are promoting a model that they call gender exploratory therapy, which has zero supporting evidence. Can you tell us more about this relatively innocuous-sounding approach?
So this approach, gender exploratory therapy, is often positioned as a neutral alternative to gender-affirming care, but it's essentially a rebranded, according to my view, form of conversion therapy. It lacks any credible empirical support and often centers doubt, delay, and pathologization, especially of trans and gender diverse identities. So I think for me, this is another form of a conversion therapy, because it neutrality, we have to affirm. So neutrality is not an option here. When you're speaking about gender affirming care, neutrality is not a point to stand on.
The United Nations has called conversion therapy human rights abuse and torture. So, equating gender exploratory therapy with conversion therapy, which is what it is, that really shows how dangerous it can be. But how has this alternatively named conversion practice come into the media attention? I believe there's something called the GAHC review.
So I can't speak much of the GAHC review, but from I know that it has gained traction in the media, and I know that it has been widely critiqued for its methodological limitations and bias framing. And I believe it's used politically to justify restricting access to care rather than to meaningfully engage with the lived realities of mental health needs of sexually and gender diverse individuals, especially those of trans individuals. So unlike this approach, gender-affirming care is evidence-based, it's trauma-informed, and it's rooted in dignity and respect. It's not experimental, but rather it's life-saving.
The anti-trans movements don't actually have anything of value to offer to LGBTQIA plus folks. So in that case, let's get back to something that is evidence-based and dive into these gender-affirming PsySSA guidelines for psychology professionals working with sexually and gender-diverse people. Can we start by talking about the development of these guidelines? What values and frameworks underpin the guidelines? You've already mentioned some of them.
Yeah, so like I mentioned, the guidelines are grounded in an affirmative, intersectional, and decolonial approach to mental health care. So the notion of a heterosexual, the notion that rather same-sex or gender diverse individuals is a Western concept, it's not true. So at their core of these guidelines is the belief that LGBTQIA plus individuals have the right to dignity, autonomy, and access to care that affirms who they are. So when we developed these guidelines, we drew on frameworks like the minority stress theory to understand how systemic oppression impacts mental health, and we used an ecosystemic lens to locate individuals within their broader social, cultural, and political contexts. And the decolonial and feminist influences helped us challenge the Eurocentric, pathologizing norms that still dominate much of mainstream psychology. And our aim was to create something both rigorous and deeply rooted in African realities, to offer guidance that is relevant, ethical, and transformative.
Affirmation is the first step. So the first guideline is adopt an affirmative stance. What does this mean, and why did it get first place?
So an affirmative stance means recognizing, respecting, and staying informed about sexual and gender diversity, and applying that across all areas of practice, not just therapy. It's about centering dignity, autonomy, and lived experiences. So I believe this is the first stance, right? You have to adopt that affirmative stance within you. This stance helps us to undo the historical harms that psychology has inflicted on LGBTQIA plus individuals in our history. We all know about that. But it's not just about avoiding harm. It's about actively creating a safe space, actively participating, avoiding neutrality, like I said. So actively creating safe, caring, and equitable spaces that includes how we teach, how we do research, how we write our policies, and even how we show up in the media. That's very important. And affirmative practice isn't blind validation. It includes space for self-exploration, ambiguity, and fluidity. But it starts from the position that identity is not a pathology. It's not the cause of distress. The systems around it are. So, and our work, when done affirmatively, helps reduce that harm and rather builds resilience.
Thank you. One of my favorite additions to this new release of the guidelines is the case studies that you've added to every chapter. The case studies make it so easy to understand how to practically apply these guidelines, not just in working with clients, but also in engaging with other queer people on a daily basis. Is there anything more you'd like to say about about the case studies before we move on?
So I think the case studies, it was about, we have these guidelines, and sometimes it's easy to read a guideline, but the case studies are more of, we did have an application section also, but we wanted to bring it closer to home. What does it look like if I'm busy involved in a policy reform? What does it look like if I have a gender and sexually diverse individual in front of me as a practitioner? So looking at you'll see the case studies are different. It looks at different backgrounds, different types of individuals that we can encounter. So for me, it was important for practitioners for us to take it a step further to say, what does it look like for me as a mental health care practitioner if I have somebody who's sexually and gender diverse in front of me, if I'm busy doing research or I'm engaging in social media. So that was, I think, that that's the purpose of the case studies.
But I love what you're saying about, making it real and making it practical. And, sometimes words like affirmation and neutrality, people might not know, okay, what does this mean in this context?
Yes,
and the case studies, make it practical. I would hope that we could all universally agree that discrimination is bad. It is unconstitutional, it's illegal, it's morally and ethically reprehensible. But the second guideline in this document is ensure non-discrimination, which shouldn't even need to be said. So what was the rationale for including this guideline?
Let's speak about non-discrimination, right? And non-discrimination is a legal and ethical baseline. I think we would both agree, but sadly, still not a given in many professional spaces. And this guideline reminds us that LGBTQIA plus rights are human rights. As psychology professionals, we are obligated to uphold dignity, equality, and justice in every context we work in, whether it's in our therapy rooms, in our institutions, schools, or advocacy spaces. So therefore, discrimination against sexually and gender diverse people isn't just interpersonal, it's systemic. I think we also need to agree on that. And as a profession, we've often been complicit in that. So this guideline is about moving beyond silence and neutrality, just like both you and I have just mentioned. It's about affirming rights through our everyday practice, including how we design our forms, how we deliver training, how we engage with policy or support LGBTQIA plus migrants and refugees. So ultimately, it's about asking, does my work challenge inequality or does it reinforce it? So I think I'll repeat that. As a mental health or a practitioner or a psychology professional, I think we need to ask ourselves, does my work challenge inequality or does it reinforce it? Because non-discrimination isn't passive. It requires deliberate, informed, and ongoing action.
Self-determination of people's sexual and gender identities enables us to live with dignity and congruence. And yet this seems to be one of the most contentious aspects of the gender-affirming approach. Only a few countries allow gender self-identification without medical or legal requirements. Most countries, including South Africa, impose some level of gatekeeping on gender self-identification or self-determination. However, the PsySSA guideline, the next PsySSA guideline, is to uphold individual self-determination. Can you tell us more about why this guideline is so important and how can we apply this guideline in practice?
Guideline 3, which speaks to upholding individual self-determination, helps us to understand that self-determination is really central to ethical and affirmative care. And what it means that it means trusting people to know who they are and supporting them in navigating how and when they disclose that identity in a world that often punishes visibility. And that is very important. As psychologists, we are called to actively respect clients' pronouns, the language that they use, and choices around medical or social transitioning. But beyond that, we also need to challenge the systemic barriers. I'm talking about the legal, cultural, religious barriers that make self-determination unsafe or inaccessible, especially if you look at Black LGBTQIA plus people in rural areas or in lower socioeconomic environment or impoverished areas. So therefore, affirming self-determination isn't about pushing visibility. It's about holding space for fluidity, ambiguity, and choice. I think this is very important. Whether someone chooses to be out or not, whether they pursue medical transitioning or not, those decisions are valid and they should be made by that said individual. And ultimately, this guideline reminds us our role isn't to steer our clients or individual into a specific direction, but our role is to support, to affirm, and to advocate for the conditions that allow people to live as their full, authentic selves. So, yeah, I think that's what self-determination is about. I think it's important that I repeat that. It means trusting people to know who they are and supporting them in navigating in how and when they disclose that identity in a world that often punishes visibility. It means trusting people on whatever journey that they are on when it comes to their sexuality and gender identity.
Thank you, Thembi. I love that. And I love the next guideline too, because I feel like even more than the ones we've already discussed, it intersects with feminist theory and ideas. It goes all the way to the top. So the fourth guideline is recognize normative social contexts. Please tell me more about normativity.
This guideline encourages us to look deeper than surface level inclusion and critically examine how social norms shape mental health, particularly for LGBTQIA plus individuals. So often, one of the most powerful forces at play is what we call heterosis normativity. And this is the idea that being heterosexual and cisgender is the default, natural, and preferred way of being for everyone. And it combines what we call heteronormativity, which assumes that everyone is straight, and cisnormativity, which assumes that everyone identifies with the sex they were assigned at birth. So together, these norms create a system that punishes or erases those who don't conform through invisibility, invalidation, or outright discrimination. And I think even within the LGBTQIA plus communities, we see what we call homonormativity, where identities and relationships that closely mirror heterosis normative values like monogamy, gender conformity, or middle class respectability are more readily accepted. And this often marginalizes or exclude trans or non-binary, polyamorous, disabled, or working class queer people. So when we apply this guideline, we are acknowledging that normal is not neutral. It's actually political. So as psychologists, we need to actively challenge heterosis normative standards in our practice, in our language, in our forms, mostly our intake forms, in our research, and in our therapeutic context. If we don't do this, we risk replicating the systems of harm that we aim to disrupt.
Thank you, Thembi. I think you've really given us a good idea of how these systems of power, marginalization, and normativity are deeply embedded in all aspects of our society. So how do we apply this guideline in a way that supports queer people?
We need to understand that we can't, when dealing with queer individuals, we can't apply a one-size-fits-all. And we need to understand that what makes up a queer individual. We need to understand that the experiences of a gay white man who lives in the suburban area and a Black African gay man who lives in the rural area, or a trans individual who live in the township, their experiences are not will not be the same. So there's no one blanket fits all for queer individuals, and their experiences are also unique to their context as well. And so the social norms that are enforced on these individuals, we need to notice how they erase some queer identities, and we need to be mindful of that in our when dealing with sexually and gender diverse individuals.
And just to say, the official guidelines use the term heterosis-normativity to describe the system of power that oppresses queer people. But folks might also have heard the term cis-heteronormativity, which swaps the cis and hetero prefixes to describe the same system. We might even have used the alternate version elsewhere on this podcast. So there isn't really a meaningful difference between these terms, but for the sake of consistency with the guidelines, we're going to try to stick to using heterosis-normativity in this episode. Now, if the previous guidelines got me excited, like the fifth guideline is even more aligned with the ethos of this podcast. As it is written, understand intersecting discriminations. What are the structural positions in society that LGBTQIA plus people embody that often lead to discrimination? How does this impact their mental health?
So yes, guideline number 5, which is understanding intersecting discrimination, also invites us to look beyond sexual or gender diversity alone and instead understand people as complex beings navigating multiple or overlapping systems of power or oppression, like you mentioned. For example, a Black lesbian woman living in a rural area will not experience her sexuality in the same way as a white gay man in an urban center. So when we look at this Black lesbian woman, the impact of racism, classism, ableism, religion, and geography, they all intersect, shaping how she's seen, supported, or excluded. So for practitioners, this means 2 things. It means that don't assume that being LGBTQIA plus is the primary concern for every queer individual. It might be poverty, there might be mental illness, or there might be religious rejection or cultural pressure. So it's important that we don't treat queer experiences as a one-size-fits-all. This guideline teaches us that context matters. It's very important. So we are called to practice with cultural humility, number 1, to listen, to reflect, and constantly question our assumptions. And this will allow us to honor each person's full humanity, not just their identity label. So looking at an individual as a whole, I look at these guidelines from a systems theory perspective, where you understand the different components that make up a human being.
Thank you, Thembi. Yeah, there are so many aspects of intersectionality to consider. One of the main purposes of this podcast is to encourage mental health practitioners and others to be more active advocates for their marginalized clients, colleagues, and friends. We dedicated a whole episode a few months ago to understanding how advocacy and activism are actually ethical duties of healthcare providers. I think this really aligns with the next guideline. So could you tell me more about counteracting stigma, prejudice, and violence? What are the practical considerations for applying this guideline?
So this guideline reminds us that stigma isn't just about name calling or discrimination. It's about an entire system that harm people's mental health, dignity, and safety. So whether it's the lesbian woman erased by being called a friend at her doctor's office, or the trans woman denied services at a clinic, these everyday acts of erasure build up, sometimes into deep trauma. And we call these microaggressions, but their impact is anything but micro. So what this means in practice is that as psychologists, we need to create safe, trauma-informed spaces and understand the structural roots of prejudice, which include heterosis normativity and the colonial legacies that still shape our institutions. It's important for us to advocate for our clients within those systems, whether it's education, healthcare, or law enforcement. We are not just treating systems. I think that's important. We're not just treating symptoms. We are dismantling structures that cause harm. And these structures still exist.
Absolutely. Love, families, and finding your people. Even allies and people who generally support or think that they support LGBTQIA plus folks sometimes say things that they don't realize are implicitly transphobic or queerphobic. For example, one of the innocently asked questions that make me so angry is, what do you think is the reason that you're transgender? Or why are you gay? Like, what happened to you? And this happens with other forms of non-normativity too, like neurodivergence. So can you explain for the listeners what the problem with these questions is and why they are actually harmful?
So these kind of questions like why are you gay or what made you transgender, might sound innocent to some, but they're actually deeply harmful. They suggest that being LGBTQIA plus is something abnormal that needs to be explained, fixed, or justified. Because we don't ask people, why are you straight? Why are you cis and not trans? It's like asking an individual what went wrong in your development, That reinforces the idea that cisgender and heterosexual identities are the default and everything else is a deviation. So Guideline 7 challenges this thinking. It reminds us that everyone has a developmental pathway, a journey that unfolds across their lifespan. And sexual and gender diversity is a natural part of that. It doesn't need to be caused by trauma, bad parenting, or confusion. When we ask these questions, even with good intentions, we reinforce heterosis normativity, the idea that anything outside the straight cisgender box needs to be explained or defended. Instead of asking why, a better question is, how can we create space for people to explore who they are without shame, suspicion, or scrutiny? That's the shift this guideline calls for, from pathologizing difference to affirming human diversity.
LGBTQIA plus people often face specific challenges with their families of origin. And so we end up forming very close attachments to our chosen families. How can we support diverse family structures and relationships, which is the next guideline?
So just like you've said that many LGBTQI individuals are ostracized by their communities, they face rejection, shame, or even violence within their families of origin. So as a result, chosen families made up of close friends, partners, or supportive networks become essential sources of love and belonging. So supporting diverse family structures mean affirming that family is not limited to biology or heterosis normative configurations. And it's important as professionals that we must create safe spaces where both families of origin and families of choice are respected. This includes navigating disclosure, supporting relational repair when possible, and validating chosen family bonds in therapy, within the legal systems, and within various institutions. So I think it's important that we understand the potential challenges of different relationship configurations, meaning that sexually and gender diverse individuals are often scrutinized when their relationships fall outside hetero and mononormative expectations. So polyamorous, open or asexual partnerships, for instances, can be misunderstood. They are often judged or seen as unstable. And the challenges may include stigma, the lack of legal recognition, or even difficulty accessing affirming care. So supporting individuals, LGBTQIA plus individuals, and the various family structures and relationship configuration means respecting the validity of their relationship choices, helping them set boundaries, and advocating for policies that don't pathologize non-traditional structures.
Thanks. As you mentioned, the LGBTQIA plus community also includes asexual people who face unique relationship challenges. How can we better support them?
I'm glad you asked this question because asexual people often face erasure or are pressured to conform to normative ideas of intimacy. They may be misunderstood by partners, families, and even therapists. So better support means that it's important to educate ourselves about the asexual spectrum. And I'm saying that it's important to accept that we may not understand asexual individuals. It's okay to sometimes say to a person, you know what, I don't understand your world. Can you tell me more about it in a respectful and affirming manner? Can you tell me more about your life? And affirming asexual identity it's important that we affirm them as valid and provide a space in therapy for individuals to define what fulfilling connections look like for them, whether romantic, platonic, or otherwise. I think it's important to remain curious and want to know more about asexual individuals, but obviously in a very affirming and respectable manner.
What challenges impact sexually and gender diverse parents and their children?
Sexually and gender diverse parents often face discrimination. I believe actually they face a lot of discrimination. They face discrimination in adoption, in fertility treatment, or custody processes. Their families may be seen as less than or not considered legitimate. And children of queer parents may also experience bullying or stigma at schools or various social contexts. So it's important as psychologists that we must support these families holistically and understand their context. It's important that we advocate for non-discriminatory systems which affirm diverse parenting identities in our work, and recognizing that what matters is not family structure, but relational safety, love, and support. But I must also mention that LGBTQIA plus parents and families are also resilient.
Yeah, I love that. Vital emotional resources for queer people are resilience and social support, as you've mentioned now. Please tell us about how Guideline 9 prioritizes relational well-being to increase these resources.
Absolutely. So, Guideline 9 reminds us that mental health is not just an individual matter, it's deeply relational. And for many LGBTQIA plus individuals, support from friends, romantic partners, chosen families, and community networks, it's a lifeline for them. So therefore, relational well-being helps us move beyond surviving to thriving. And therefore, Guideline 9 pushes us to understand resiliency not only as an individual trait, but as something built and sustained within a system. And this system could be families, communities, and even institutions. It challenges the old idea that queer people must just cope and instead asks, how do we create environments where they can flourish?
What are some examples of this in action?
This could look like helping a trans teen build a network of affirming peers after facing rejection at home or at school. Or another example is supporting a couple navigating minority stress and teaching dyadic coping skills. Or another example is also advocating for LGBTQIA plus support groups at clinics or at schools. I think that is also important. And I think it's also important to highlight role models like Caster Semenya and the likes of Zanele Muholi, who show us what resiliency and community solidarity can look like. And ultimately, we're not just treating individuals, we actually really supporting their ecosystems.
Absolutely. Thank you. I think that was a great answer. The work starts with us. We've spoken already about why an affirmative stance is so important in our discussion of Guideline 1, and also why we need to recognize normative social contexts, which was Guideline 4. So can you say more about how Guideline 10, which is affirm diversity and resist normalization efforts, differs from those?
So Guideline 10, which is affirm diversity and resist normalization efforts, takes the ideas from Guideline 1 and Guideline 4 a step further. So while Guideline 1 focuses on adopting an affirmative stance, and Guideline 4 asks us to critically recognize how social norms shape experience, Guideline 10 calls for active resistance. It's not enough to passively affirm. This guideline asks us as psychology professionals to challenge efforts to pathologize, silence, or erase sexually and gender diverse people. This guideline draws attention to how so-called normalization efforts like conversion therapy or non-consensual surgeries on intersex infants are actually acts of violence, even when framed as medical or moral care. These practices aim to force LGBTQIA plus people to conform to heterosis normative ideals, and they can cause lasting harms.
I love the case studies in this chapter, and I think they really bring to life some of the issues that you've just spoken about. Could you please talk us through one of them?
So one of the case studies that really illustrates this is the story of Mpho and Thandi, who are new parents of an intersex baby. Their baby is Nandi. Doctors encouraged them to approve immediate surgery to fix Nandi's body. Surgery that wasn't medically necessary and would have lifelong consequences. But instead of following that advice, the parents paused and questioned whether that was truly in Nandi's best interest. Was that truly in the best interest of the child? So the fact that they're questioning this moment, for me, it's powerful because it shows how parents with the right support can resist societal pressure and protect their child's bodily autonomy. And so this guideline reminds us that affirmative practice also means advocacy. It means standing with families like Mpo and Thandi and helping them make informed ethical decisions, especially when the system is pushing them towards conformity.
That case study is such a beautiful example of parents advocating for their child. Many traditionally trained healthcare professionals become very used to being the expert in the room. But from a person-centered, decolonial, and intersectional perspective, we need to remember that the client is the expert on their own lived experience, and that we also have things to learn and areas in which to grow. So Guideline 11 addresses this by saying that mental health professionals must disclose and rectify personal biases. Please tell us more about this in the context of sexually and gender diverse people. What does this look like in application?
Yeah, so guideline number 11 reminds us that affirming care isn't just about individual clinicians doing better. It's also about systemic transformation. However, it also challenges us to do the deep work on examining our own biases. That's what I was saying, including the biases that are shaped by our religious systems, by our heterosis normative systems, and colonial systems. Basically, the societal norms that we exist within. And not only do we exist in these systems, these heterosis normative systems, the colonial systems, we are also trained within the systems, most of us. So even well-meaning therapists may unconsciously uphold harmful assumptions. For instance, expecting all clients to be monogamous, sexual, or to identify with binary gender frameworks. These assumptions can invalidate the very same individuals that we want to affirm or protect, as they can invalidate the experiences and compromise the care that you're trying to provide as a healthcare professional. So what this looks like in practice is that we must actively reflect on our biases, including through supervision, training, and self-assessment tools. If we lack the competence to work affirmatively with clients, I think the ethical thing to do is refer. And that's the responsible and ethical thing to do, without and I'm speaking about responsible referral, without you abandoning the client, because that can also happen. So if you feel like you're lacking competence, make sure that there is responsible referral. And importantly, it's important to note that even LGBTQIA plus professionals are not immune to internalized biases. And cultural humility must always guide us all. And we must remember that ultimately this is about ethical care. Our discomfort or limitations are not excuses for poor service. They are a call for us to do better.
I love that. The final guideline calls on us to enhance practice through continuing professional development. CPD is a requirement for all of us who are registered with the Health Professions Council of South Africa to maintain our registrations. But even basic training with LGBTQIA plus people is scarce compared to other areas of focus. Where and how can we improve our ability to work affirmatively with sexually and gender diverse people?
guideline number 12, like you're saying, it reminds us that affirming practice is never a once-off commitment. It requires ongoing learning. For example, most of psychologists who were trained, let's say were trained a couple of years back, they didn't have training on how to deal with gender and sexually diverse individuals. So we need to understand that. That's why there's the importance of continuing professional development. So it's important to understand that as psychologists, we are ethically and legally obligated to stay up to date through CPD that specifically include content on sexual and gender diversity, because too often LGBTQIA plus content is missing from formal training. So the CPD becomes essential in bridging that gap, helping us understand lived experiences more deeply. And it also helps us to apply ethical frameworks in context and challenge our own biases and assumptions. So it's not just about getting CPD points. It's about cultivating cultural humility. It's about critical reflexivity and readiness to meet the evolving needs of clients. Whether through workshops, supervision, research, or community engagement, CPD is how we sharpen both our competence and our ethics. And it's important to remember that if we are not learning, we are likely causing harm.
Thank you. I think that's a really important reminder. As we wind up this episode, would you like to share what is on the horizon for you?
I'm currently in the early stages of my PhD research, which will explore the psychosocial experiences of Black immigrant lesbian women living in South African urban and township areas. I think this group, their realities are often invisible in both research and service provision. I'm also continuing my work through the African LGBTQIA plus Human Rights Project, and we are excited to be going to Limpopo in the next month of August to launch the guidelines. This will be our first launch in a rural, non-metro area, so I'm looking forward to that, and I'm excited about that. And the African LGBTQIA plus project, we're just continuing advocating for affirming rights, affirming right-based mental health care across South Africa and the rest of the continent. I'm still working with PsySSA, executive member of the sexually and diverse division there. And I'm looking forward to also starting my community service here.
Wow, you didn't waste any time getting onto the PhD train. Good luck with that. And I'm really glad that you are taking these guidelines out into more rural areas and spreading this knowledge far and wide.
Awareness, visibility, I'm excited about that. And also hopefully to meet with the civil society from there, just like we did in Cape Town, we had gender dynamics with some members from the Triangle Project. So I'm looking forward to going to Venda to create awareness and to also hopefully practitioners who will have these guidelines to start practicing them, to start providing affirmative care.
Yeah. And where can listeners go to find out more about you and your work?
So, like I said, we have a website on the African LGBTQIA plus project, but I have my own personal Instagram page, which is Mind Matters with Thembi. So it's mindmatters.with.thembi. Yeah.
Great, thank you. I'll put a link to all of that in the show notes. Thembi, thank you so much for your time. And for your contributions to these guidelines and for the work that you're doing. Yeah, I really appreciate it.
Thank you. Thank you, Aurora. Thank you for having me. I really appreciate it.
Thanks so much to Thembisile Dlamini for her patience and commitment to this topic, and for giving so much time to recording and re-recording this episode. And thanks again to you, the listener, for your support and engagement. Look after yourself. And remember, everyone deserves to live with their optimal mental health. Thank you for listening to Intersectional Psychology. Please follow or subscribe to the podcast to get every episode. If you enjoyed this episode, please rate and review Intersectional Psychology in your preferred app. It really helps other people find the podcast. This episode of Intersectional Psychology was researched, written, recorded, and edited by me, Aurora Brown. For a transcript of this episode, please see the link in the show notes on your podcast app or go to intersectionalpsychology.com. You can also check the website or the show notes for a full list of references for this episode. A video of this episode with closed captions is available on youtube.com/@intersectionalpsychology. To support this podcast and get access to bonus content, including additional episodes and interviews, as well as more guided mindfulness sessions, please go to patreon.com/intersectionalpsychology. You can also chat with me on Blue Sky at intersectpsy.bsky.social and Instagram, Facebook, or TikTok at Intersectional Psychology, but mostly Blue Sky. Aurora Brown and Intersectional Psychology are committed to the Cite Black Women praxis. All episodes of Intersectional Psychology are for educational purposes only and are not intended to be a substitute for professional mental health advice, diagnosis, or treatment. I, Aurora Brown, am not able to answer specific questions about individual situations. Always seek the advice of your health provider with any questions you may have regarding a mental health condition. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen on this podcast. If you think you need immediate assistance, please call your local emergency number or any mental health crisis hotline. Everyone deserves good mental health.